Alrighty, hello friends. Welcome to your first review of the new unit, HIV, cancer, AIDS, all the fun stuff. This unit is very quick, very fast. I haven't even looked to see when your guys' exam is. Probably, oh, it's next week. Nice. Okay, how? I just talked to Dr. Schneider this morning and he said you guys were doing cancer today. So how is your exam next week? I don't know. Okay. Well, I will do your reviews, don't worry. So my plan is to do this cancer review, which is just like overview, um, some stuff about like treatment, oncologic emergencies, and then I will do a separate video on like types of cancer and what you need to know. It's definitely not as overwhelming as it looks, and I've already told some of you guys, but this was definitely the best exam for my cohort. And like that's what our peer leader had told us. He had said that this was the easiest exam. I'm kind of an overthinker, so I got the same exact score on the first three exams. I think I got 92 on all three of them. But I do know that for this exam, the stuff I missed was stuff that I knew, and I just like second guessed myself. And then the last exam was my best, but that's because it's musculoskeletal and I work as an SNT on ortho. So, like, it was all second nature to me. But anyway, so yeah, but I'm gonna do this cancer review video and then I'll do another one and then HIV and get you guys all golden. I don't like this glare. Okay, that's a little better. Okay, so cancer. Okay, so a little bit just like an overview with cancer. Oh, I need to set an alarm. I'm in virtual clinical today, but I finished all my stuff, but we still have to meet for a conference. Sorry. I'm like, y'all, fifth term, I'm just telling you, so relaxed, but I feel like I'm just a hot mess express because I don't know what's going on any of the time. Okay, cancer is most common or second most common cause of death in adults. Heart disease, as most of you guys probably know, is the leading killer. Cancer deaths are actually on the decline, and that is something that I recently read an article on. I think most cancer deaths nowadays are in like patients that have other comorbidities, and patients that are obese. So that is improvement. It as far as like what causes cancer, there's lots of different things that are thought to like cause it, but on the other hand, there's things that we don't know why certain people get cancer. You know, you look at like lung cancer patients and like some smokers will get it, some smokers won't. There'll be people that get lung cancer that have never touched a cigarette in their life. So, you know, it's kind of one of those topics that's just like we know some stuff but we don't know everything. But bottom line is the etiology behind it is cancer is a disease of uncontrolled cell division related to change in the activity of the cell cycle regulators that normally inhibit the cell cycle from dividing when conditions aren't right. So basically what that means is that there is something in the cell cycle that like there's regulators that usually will like prevent your cells from dividing during unnecessary conditions. But in cancer patients, those regulators are either like inhibited, don't exist, and so you just have cells dividing constantly. And so generally cancer, I have this bolded, is due to gene mutations in genes that code cell regulator proteins. Because like I said, those regulators are either messed up or they don't exist. Cancer cells are very, very smart, so they can actually like make their own growth factors that are just like stuck in the on position and like trick the rest of your body into thinking that they're necessary for survival, which I think is pretty crazy. Like, I don't know. Like your body is just so weird. Other regular, oh my gosh, I told you guys, I'm a hot mess express. Other random little things about cancer, Lung cancer is the deadliest in men and women, with prostate and breast cancer as the second and colorectal cancer as the third. Smoking is the number one cause of cancer. I'm sure you guys maybe remember Gurley. Gurley like talked about smoking every day. Other little things I have, so cellular regulation, that's when that's all the functions that are normal within our cells to maintain homeostasis. And then proliferation is the production of new cells through cellular division. Neoplasia is abnormal replication of cells that causes a tumor. Benign is normal cells. Abnormal presents with tumors. So those are just kind of some definitions of just like some, oh my gosh, I can't. These are just like some definitions of things that you guys need to know for like the process of cancer. Okay, tumor cells, I just kind of talked about this. So benign, this is something that you need to know. Those first couple things were just kind of like random little overviews that might help you with the content, but it's not necessarily like test material. Definitely need to know this. So benign tumor cells are a mass of cells that divide too much, so they lack those cell regulators, but they do not have the potential to metastasize. So they're well differentiated and they aren't cancerous, but that doesn't mean that they like don't have the ability to affect us, because they can grow pretty large and they can press on healthy tissues, which can cause a whole bunch of problems. So know what benign tumor cells are, but malignant tumor cells, on the other hand, are a group of cells that divide too much and they have the potential to mutate over time and increase this pool of cancerous cells. So they can be well differentiated, undifferentiated, but they have the potential to grow large, press on healthy tissues, and can invade surrounding tissue to metastasize. So benign tumor cells cannot metastasize, whereas malignant cells can metastasize. Okay, so grading and staging cancer. This is definitely something that will be on your exam. So grading cancer is a description of the tumor based on the abnormality of the tumor cells, and how the tissues look under a microscope. So it can be an indicator of how quickly a tumor is likely to spread and grow. That is important. Well-differentiated cells, so these cells look like normal cells and they have the same organization, but they're slower growing, whereas undifferentiated cells don't look like normal cells that are supposed to be there, and they are more likely to grow rapidly and spread. So the way that we determine this is if we suspect there to be an area that could be malignant, could be cancerous, then we're going to remove either part or all of that tissue during a biopsy, and then a pathologist is going to examine it, determine its grade and other characteristics. So I would know that definition of well-differentiated versus undifferentiated, along with what grading cancer indicates. So then the differentiation of cancer. So you have GX, which is not determined, to G4, which is undifferentiated. So then you have G1, G2, G3, and G3 all in the middle. So GX means that the pathologist removes that tissue and can't determine what the cells look like. G1 means that the organization of the tumor tissue appears to be close to normal, so they grow and spread slowly. So this is well differentiated and low grade. G2 is moderately differentiated, intermediate grade, and then G3 is poorly differentiated. G3 and 4 both don't look like normal cells and tissue, and they're both going to grow faster and spread easily. But G4 is completely undifferentiated, very high grade. So I would know that. It seems complicated, but if you just take the time to read through it, you realize it's really not that bad. So there are different types of grading scales that can be used for different types of cancer. I don't remember there being, I don't think there was anything about this actually there might have been something on the Gleason scale. The only two that we talked about were prostate and breast cancer. So there's like two different, wow, closing the blinds really did nothing to that glare. I am sorry. So breast cancer, we use the Nottingham grading system, and it grades the tumors based on tubule formation. So that's like how much of the tumor tissue has normal breast duct structures. Nuclear grade is an evaluation of the size and shape of the nucleus in the tumor cells, and mitotic rate is how many dividing cells are present. So that measures like how fast the cells are growing and dividing. And so we look at those things, and then we use a score of 1 to 3. So 1 means the cells look most normal, and 3 means they look abnormal. And so how we like grade it, so if they have a 3 to 5, so basically you take that 1 through 3 and you apply that to each of those categories that I just talked about. So like the tubule formation, the nuclear grade, and the mitotic rate. And so you like grade them and then you add them up. And so if your score is between 3 and 5, then you get the stage of G1, which means that they're well differentiated, low grade. Remember what that means. If you get 6 through 7, that means they're G2, so that's like intermediate, moderately differentiated in grade. And then 8 through 9 is high grade, poorly differentiated. And then prostate cancer, we use the Gleason scale. And so I do remember something on the exam about this. So basically when we suspect there to be prostate cancer, we take so we look at a primary and we look at a secondary pattern of tissue organization. So we look at the most common tissue pattern under a scope and then the next most common. And so each pattern is given a 1 through 5 grade. And so 5 is the most abnormal, 1 is the most normal, and X means can't be determined. And then you like add them up. So Gleason X, anytime you have an X, that means that it couldn't be determined. Gleason 2 through 6 means that the tissue is well differentiated. 7 is moderately, and then Gleason 8 through 10 is poorly differentiated or undifferentiated. So that is all about grading cancer. I know that seems like a lot, and I know it probably seems like overwhelming, but like I said, if you go through and you just kind of remind yourself about what like differentiation is and like what poorly differentiated means and like that kind of thing, it's really not that bad. I think that the important thing to remember is that grading cancer is can be an indicator of how quickly a tumor is likely to grow and spread. That's why we grade cancer. We're looking at what cells are well differentiated, what ones are undifferentiated. So remember that, remember those definitions, and you guys should be just peachy. So then the next thing is staging cancer. So staging cancer, on the other hand, looks at like location, lymph node involvement, size and extent of the original primary tumor and the number of tumors present. So it's important to recognize like the difference between staging and grading. So like I said, with grading, that kind of just tells you like how likely it is to grow and how likely it is, like how quickly it is to grow and spread. Staging looks more at like involvement and like location, if that makes sense. So this looks at like, is there a tumor and has this tumor spread in the body? So what I have bolded is it tells us about the spread of cancer cells in the body. You will have to do this on your exam. So very, very important to understand staging. So we use the TNM classification system. Some cancers are staged differently, like leukemia and blood cancers, but that's not what you're going to be tested on. That's not what you need to know. So there's TNM, oh my gosh, 3 categories. So T stands for primary tumor. It's important to know that we use the primary tumor when we're determining staging. So if your cancer has spread to your lymph nodes, we're not going to use the lymph node tumors to like grade, if that makes sense. If it started in the lungs, then we're using that lung tumor. So primary tumor, which is your T, is the size and extent of the main tumor. So T0 means the tumor cannot be found. T-IS is IS. is in situ. I don't know if that's an abbreviation for something or that means that the localized cells show no local tendency to invade or metastasize. And then T1 through 4 refers to the size and extent of the primary tumor. So the higher the number, I have this bolded, the higher the number, the larger the tumor, and the more it has grown into nearby tissues. So this means that there is a tumor. So, if you have T0 or T-IS, there's no tumor. If you have T1 through 4, you have a tumor. TX means that it cannot be measured. Okay, actually, let me take that back. T0, there's still a possibility to be a tumor, but it just like cannot be found. And then TX cannot be measured. So that's talking about the size and extent of the tumor. So that is T. Regional lymph node involvement is the N. So that's the number of nearby lymph nodes that have cancer. So N0 means there's no cancer in the lymph nodes. N1 through 4 is the number and location of the lymph nodes that contain cancer. So once again, higher the number, the more lymph nodes that contain cancer. And then NX means it cannot be measured. And then distant metastasis is the M. So that's looking at whether the cancer is metastasized. So M0, no metastasis, M1 through 4, sites that have had metastasis, and once again, higher the number, the worse the metastasis is, and then MX, it cannot be measured. So the thing you're going to have to do on your exam is Schneider's going to give you a TNM like example, and you're going to have to like understand what that means. So the example that I have on my doc is T2, N1, M0. T2 means there is a tumor. Remember, for the sake of your exam, T0 and TX and TIS means no tumor. T1 through 4 means there is a tumor. And then N1 means that there is lymph node involvement, but M0 means there's no metastasis. And that's literally all you need to know. You just need to be able to determine, is there a tumor, is there lymph node involvement, and is there metastasis? Alrighty, moving right along. So metastasis, going a little more into that. Metastasis is the spread of cancer cells through blood or lymph nodes distal to the primary tumor site. So like common sites are the brain, lungs, liver, adrenals, and bone. Like I said, we always refer to cancer that has spread in terms of its primary site. So even if you have lung cancer now because you had brain cancer, you're still going to say you had brain cancer with liver metastasis or with lung metastasis. I can't even remember what I said. So signs and symptoms you're looking for is just like new pain in an area, new onset confusion and falls, change in bowel and bladder, just anything that's different. Cancer cells gain the ability to move, and like I said, they're smart, so they can outsmart the body to make new blood vessels and support their growth with oxygen and nutrients so that they have this ability to like move throughout the body. And cancer cells do not undergo programmed cellular death, which, if you remember, is called apoptosis. Naming cancers, I think we had like one question on this on the exam. So basically just know like carcinoma means tissue of the epithelial, cancer of the epithelial tissue. So like linings of the internal organs, basal cell carcinoma, examples. Adenocarcinoma is a glandular organ tissue that usually forms in mucus secreting glands. It can happen in many places like the lungs, pancreatic ducts, intestinal gland cells, but most common that I have highlighted is that the line the colon and the rectum. Sarcomas are connective or supportive tissue cancers, so like bone, cartilage, muscle, blood vessels. Leukemia is blood-forming cells in the bone marrow, and then lymphoma is lymph and immune system cancers, so like myeloma. Like I said, I don't know if we had a question on that. I think we had one, but it was like very straightforward. I would just know like all those types and like what they are. So like I said, carcinoma is epithelial tissue, for example. So then This will definitely be on your exam. Warning signs for cancer. So we use the acronym CAUTION. I know we had this on the exam and it was select all. So the C stands for changes in bowel or bladder habits. So like one thing we'll talk about with like bladder cancer, for instance, is usually due to smoking. So like that's one example, like you notice this change in your bladder due to bladder cancer. But it could be ureter, spine, kidneys. Just know C stands for change in bowel or bladder habits. A is a sore that does not heal. U is unusual bleeding or discharge from any body orifice, so like blood cancers, GI cancers. T is thickening or a lump in the breast or elsewhere. Lumps are non-tender and fixed. Very important to remember. So that's why we do breast and testicular self-exams. I is indigestion or difficulty swallowing, so that might be like esophageal cancer. O is an obvious change in a wart or mole, which is obviously skin cancer. And then N is a nagging cough or hoarseness, so like with lung cancer. I have just a couple things on cancer prevention, risks, and screening. So risks, increased age is definitely a risk. So like older women tend to develop more like lung, ovarian, and colorectal cancer, and then older men tend to develop prostate and pancreatic cancer. Genetics, HIV, any sort of immunosuppression also puts you at risk. Chronic irritation or trauma, so like alcoholism, if you have like GERD, like really frequent GERD with like Barrett's esophagus. Smoking, we already talked about, is like number one risk factor. Chronic disease, obesity, poverty, pollution is a really big one. Those sorts of things. Cancer prevention, so we talked about in my class. So we obviously talked about like exercise, healthy BMI, you know, all those things that you guys have probably been hearing since you were in like elementary school, you know, get active like 30 minutes a day, eat a healthy diet, make sure you're following the screening recommendations, which I will talk about here in a second. That doesn't really prevent cancer, but it can help you to like catch it early. You want to limit alcohol use, so no more than 2 drinks for men and 1 for women a day, since they have a lower body size, water weight, and more active GI. Low-fat diet with increased fruits, vegetables, and fiber. That's the whole diet thing. Limit amount of sugar and salt. Avoid smacking. Oh my gosh, guys, I'm literally like, I can't. Avoid smoking and tobacco products. So like I said, smoking is the leading cause of cancer and impacts more than just the lungs. You want to make sure you're using sunscreen with 15 or more SPF. Get your HPV vaccine, which is the Gardasil one. So I believe you can get this up to like 45 years old. Most people get it when they're in like their teens. So like I remember I got it, I think I was like 12, 13 when I got it. And then also get skin checked and remove moles that could cause changes to the skin. Like I said, screening, so this is important to know. So mammogram we're going to do every year for women over 40. Clinical breast exam every year for women over 40 and every 3 years for women 20 to 39. Colonoscopies every 10 years starting at 50 unless something is found. And usually if they find something, they do like every 5 years. Digital rectal exam is annually for men over 50. And then like obviously there are exceptions to this. So like if you have a family history, if you know that you have like a BRCA mutation, for instance, like they're going to screen you a little more frequently and potentially a little earlier. Another thing I have that I think should go under risks, but I for some reason have it under screening. So BRCA mutations are increased in, I can never say this, Ashkenazi women, so like Jews with no family history. And BRCA, remember, impacts, I believe it's breast cancer. Okay, so that is all I have on cancer, just like overview. So let me look at how long cancer treatment is. I have 20 minutes until I gotta be in a conference. Okay. I'm gonna start on treatment then. Okay, so treatment for cancer. Lots of things that we talk about with cancer treatment. Oh, this is also oncologic emergencies. That's why. Okay. So cancer treatment, we can do a couple different things. So there's a surgical intervention, which is obviously like the oldest form of cancer treatment. It can be curative, supportive, palliative. You can combine it with other forms. It can be given, or you can be done before or after chemo. But obviously surgery is like very invasive and we're not going to do it unless we have to. Radiation is, okay, surgical is not the oldest form, it's just an old form. Radiation is the oldest cancer treatment method, and the goal is to break down DNA and chemical bonds of the cancer cells, causing cell death. So there's a difference between internal versus external radiation. So internal radiation is known as brachytherapy, and it's the placement of a catheter directly into the tumor so that when the radiation is delivered, it causes less damage to like surrounding healthy tissue. Whereas external, which is teletherapy, is the most common form, and it's when a linear accelerator is used, usually with like gamma knife cobalt, and it provides high amount of accuracy. Obviously, though, there is a risk to surrounding tissues when you do this type. One thing that's really important with radiation is that they might put marks or tattoos on a patient during like a simulation so that way they know like where exactly to aim the radiation. It's very important to educate your patients on how they should not like scrub these off. They need to keep these on because it's going to show where their treatment goes. So then there's a couple other different types of treatment that are a little bit like smaller, I guess, that we didn't really talk about too much. So like biological immunotherapy boosts and manipulates the immune system to directly attack cancer cells. So basically we want to alter the body's response to these cells. Targeted therapy targets cell receptors that are important for tumor growth, but it doesn't damage the surrounding tissue. So this type of therapy does less damage to healthy cells. Hormone therapy is usually used in breast and prostate cancer. So like, for instance, men can inject themselves with hormones to decrease testosterone. But it can cause a lot of side effects like flu symptoms, orthostatic hypotension, tachycardia, all that fun stuff. Then we have gene therapy, which introduces genetic material into cells, but this is pretty investigational. We don't know much about it and its effectiveness. I can never pronounce this. Hematopoietic stem cell transplant. So bone marrow transplant, or BMT, and peripheral stem cell transplant, PSCT. So this is when a high dose of chemo, with or without radiation, is given with the idea of wiping bone marrow of cancer cells, and then we transport healthy stem cells in hopes that these will like rebuild and overtake the cancerous cells. This is very risky because obviously we're going to wipe out a person's immune system, so they're not going to be able to fight infection during this time, which is why these patients are on strict infection protocol. Very important to remember. Also important to remember that pancytopenia is a deficit in red blood cells, white blood cells, and platelets. And then neutropenic precautions are when we have an ANC, so an absolute neutrophil count less than 1,000. And this is when we might have to give like Neupogen, for instance, for like white blood cell growth. You can also use Epigen for red blood cell growth. Wait, are those the same thing? I don't think so. Neupogen. No, Neupogen is filgrastim. But yeah, so these patients are going to be on strict infection protocols. So make sure they're not getting like fresh flowers and fruits. They're wearing masks if they leave their rooms, and their visitors are being monitored for like flu and stuff. And then the biggest one here is chemo. So chemotherapy depends on the tumor factors, so like what it looks like, where it is, and it's a really big challenge as to like what you use specifically for chemo. But these are like specific to a patient's cancer. So like what one lung cancer patient gets for chemo might be different than another. Lots of things that we have to look for chemo. And this obviously goes through usually through like IV, but it can be given PO, IM, sub-Q, central lines. We can give it in the spine, lots of different things, continuous infusion pump. So with that being said, since it can be given IV, it's really important to watch for infiltration and extravasation. I can never say that. Which is necrosis of the skin. So remember, if a patient has infiltration of their IV, the IV site's going to be like swollen, might be like kind of bouncy when you touch it, and then it'll be like red. I mean, you'll be able to tell if you've ever seen somebody's IV blow with like infiltration. It's very obvious. I had a patient once, and I mean, literally like her IV was in her hand, and like pretty much all from her hand up was just like a balloon. So then there's a couple different catheter types that we can use for if we go like the central route. It's really important to know though that these types have a big risk of infection because they end in the heart. So there's a tunneled catheter which ends in the right atrium of the heart, and this is tunneled under the skin into a vein in the neck or the chest. PICC line is the most common that I'm sure y'all have all seen before. So this terminates in the superior third of the distal vena cava that we verify with X-ray. Very big risk for clots along with infection. And this is a sterile procedure. Very important to remember when we flush PICCs, we don't get to the very end of the flush because it can actually pull blood back. So you're gonna flush, pause, flush, pause. You kind of like agitate it too. And then the caps get changed with tubing as well. We have implanted ports, there's infusion ports. Usually infusion ports are continuous and they're like in the tumor. Central access, so like a portacath, this goes underneath the skin. It's like a little round port. I had a patient at clinical last term that had one of these, and it's literally just like you can see it and you can feel it. This is good if they have like lots of blood draws and pokes, and when it's not in use, we're going to lock it with heparin. Also a sterile procedure, and it gives good blood return. The thing that we talk about with chemo the most, chemo and radiation, is nursing management, because there's lots of side effects from chemo and radiation, as I'm sure you guys all know. So this is probably what you will be tested on the most when it comes to these treatments, is just like the nursing interventions and how to like manage your patients and what they're reporting, because as you guys know, Dr. Schneider loves nursing interventions. So first off, we have fatigue. So it's really important to educate your patients on how, if they have fatigue, this doesn't mean that the treatment's not working. It just takes time, extra effort for the body to repair damage from the treatment. It could also be from like a lack of sleep. Anemia can wear you out because remember, you don't have as much oxygen supply, toxic substances in the body. And so the nursing interventions for this would be maintain good nutrition, hydration, and rest with activity, like walking to boost your mood. GI is like the most common. So you're going to have decreased saliva due to parotid gland dysfunction, mucositis, which is like upper GI ulcers. And you can also have ulcers like in the stomach, so stomatitis. And so this is usually with head and neck radiation. Or not in the stomach, just like basically anywhere. Very, very important. These nursing interventions that I'm about to say, make sure you know. I know we had a question on these. So if you have a patient that has stomatitis which, like I said, is more with head and neck radiation, you're going to encourage them to use Magic mouthwash, lidocaine before they eat, rinse with 1 teaspoon of salt with every liter of water, and use a soft toothbrush. They can also have nausea and vomiting, so that can occur like before chemo, after chemo, whenever. So we're going to make sure we give antiemetics. So know your antiemetics like Zofran. They can also get diarrhea, so you want to watch for skin breakdown and give them anti-diarrheal or antispasmodics as needed, and give them a low-fiber diet if it gets too out of hand. And then on the contrary, they might have constipation, so you would give your stool softeners like Miralax or like Senna. Senna, that's what it's called. Anorexia can happen because they're just not eating very much because they're not hungry and they might be vomiting a lot. So appetite stimulants like Mrinal can be used, Mrinal. Pretty sure we had a question on that. And then hepatotoxicity can also occur. Once again, I'm going to repeat these nursing interventions. So you want to make sure they clean their teeth, moisten food, offer saliva substitutes, 1 teaspoon of salt and 1 liter of warm water to rinse mouth, meticulous mouth care to prevent infection, and you want to weigh them twice a week, especially at week 4 due to the peak of their treatment. So then moving on from GI, so other side effects can be integumentary. So a lot of time their skin tends to dry and cracked when they get chemo and radiation. So aloe vera is a good choice for when skin is drying and cracking, and then normal saline is good for like wetting the skin. Alopecia can happen, radiation damage to the skin. We might even delay radiation by like a week or 2 if it's a really big problem. And Silvadene and Aquaphor can be used to help maintain skin integrity. For GU, they can have cystitis, reproductive dysfunction, nephrotoxicity, testicular failure can occur, and infertility can occur. So we want to make sure we educate our patients on that. Nervous system, they can get ICP from edema in their central nervous system and peripheral neuropathy. Respiratory dyspnea and pneumonitis are really common, especially 1 to 3 months after their treatment starts. So they might have like pulmonary edema from the chemo or a cough and shortness of breath. Hematology, really important. I would say the GI and the hematology ones are the most important. I don't know anybody from Warrenton, Missouri, so stop calling me. So obviously we're gonna suppress their bone marrow if they get there's a lot of treatments that can do this. So their white blood cells, platelets, red blood cells are gonna be decreased. Radiation only affects the bone marrow of the field that it's radiating. I don't know why I have that. But yeah, so remember that pancytopenia, so white blood cells, platelets, and red blood cells can be decreased. So they are at risk for bleeding. They might have more bruises. They're at risk for infection. So your interventions are going to be infection control. So like I said, don't bring fresh flowers, screen the visitors. You want to keep them out of community settings, wear a mask if they leave their room, hand hygiene, no fresh fruits and vegetables, and know they're at a risk for bleeding, so you want to do those bleeding precautions. So like you're not going to floss their teeth, for instance. And then you might have to give them Procrit or Epigen for anemia, and because if they have anemia, they're going to be fatigued, and that will help stimulate the red blood cell production. Cardiac, you can get myocarditis, PE, pericarditis, EKG changes. I don't really know anything else about that. Cognitively, chemo brain is a huge thing, so they might have issues with thinking and memory. Biochemically, they can get hyperuricemia, so increase in uric acid levels from cell destruction, so they might need allopurinol, which if you guys remember, we use allopurinol to treat gout. So the same thing, we can use this drug to make sure they have healthy uric acid levels. Psycho-emotionally, obviously they're probably going to have just about any emotion possible, so it's important to use like your therapeutic communication, let your patients vent to you, and just be there for them. And late effects, so treated patients might be at risk for other secondary malignancies, so it's obviously really important to teach them like, hey, if you notice something is wrong, something's different, like, speak up. Okay. And then I have more nursing interventions. Yeah. Okay, more nursing interventions. So this is just like in general for cancer patients. So nutritional support. So patients tend to report changes in their diet. So foods might be bland, they might not be hungry. So we want to recommend high protein and calorie foods to make sure they're getting appropriate nutrition. Might need supplements. Use mild spices to enhance taste, and we want to avoid foods that they don't like due to taste alteration. I think we had a question on that. We also don't want to give them spicy or acidic foods if they have mouth ulcerations. We just talked about infection protocols. Call a doctor if temperature is above 100.5, and know that patients that are on neutropenic or immunosuppression, they might not show signs of infection, so that is important to keep in mind. And then pain management can be from the cancer itself or the treatment, because the cancer in the tumor might press on organs and nerves, and treatment can damage nerves and cause pain. So acute pain, remember, is short-term, chronic is long-term. We can have lots of different kinds of pain. So neurogenic would be that like numbness and tingling. Organ pain is deep and sharp. Somatic is throbbing or dull in the bone and connective tissue. And then phantom can happen when the body part is removed, but you still experience pain. And breakthrough pain is pain that just like happens randomly. You want to encourage patients to keep a diary of their pain, so note intensity, time, what triggered it, what medications were taken, how long it lasted, anything else that they think is important pertaining to the pain. And you want to encourage them to take pain medications. So like opioids are usually used for moderate to severe pain and breakthrough pain. And some examples are like morphine, oxycodone, fentanyl. You guys know opioids. So fentanyl, some important things to keep in mind. We can use a buccal film, PO spray, etc. And it can be a patch that's usually placed for 48 to 72 hours. So it's not immediate delivery, it's more over time. So you wouldn't want to use this for patients who have like breakthrough pain and need it right now. You would want to use this like over time to prevent pain. Obviously, opioids require a witness. XR is extended release, and these have long-term coverage for like 1 to 2 times a day. IR is immediate release, and sometimes we can combine pain medications with Tylenol to increase the effectiveness. Okay, sorry, my internet got kind of funky. I don't even remember what I was... Oh, okay, so talking about opioids, you guys have talked about side effects of opioids a lot, I'm sure, in like other classes and stuff, but we did talk about it a little bit here. So it's really important to know like how you would treat those opioid side effects. So for instance, we have nausea, vomiting, urinary retention, orthostatic hypotension. But biggest one that we talked about was opioid-induced constipation. So you want to know how to treat this. So we can give drugs like Miralax, Piricolase. One that I have here that we talked about that I never heard of was Movantik or naloxegol. So this blocks mu receptors in the gut to allow a bowel movement and is given PO. Side effects can cause opioid withdrawal, so like sweating, chills, diarrhea, pain, anxiety. You can also have a perforation in your GI tract, severe stomach pain, and diarrhea. And you do not want to take this if you have a history of intestinal obstruction. Relisor is the other one, or methyl naltrexone bromide. So this can be given PO or IM and should also not be taken if you have a history of a bowel blockage. And this can cause perforation, stomach pain, those same things. Also know that with opioids, oversedation is possible and respiratory depression. So in this case, we would give Narcan or naloxone. This is used for opioid reversal, and it's usually IM in the hospital, but can be given IM intranasally or sub-Q in the community. So I have this highlighted. The dose is 0.4 to 2 milligrams, and you may repeat it every 2 to 3 minutes. A lower dose of 0.1 to 0.2 milligrams can be used for patients who have opioid dependence to avoid acute withdrawal. So this is ordered for respiratory depression, and you give it until they have a normal respiratory rate. So, if you give it and your patient is still breathing at like 5 breaths per minute, 5 minutes later, you're going to give it again. And most of the time, patients have to have more than one dose of this to get back to normal. Another thing with opioids that we talked about is about a PCA pump. So this is obviously a pump that patients can press that'll give them a dose of medication for breakthrough pain. So some allow for boluses, but bottom line is the order should include basal rate, demand dose, lockout time, and max dose per hour. So your basal rate is the rate that's always going in the background. Demand dose is how much they get when they push the button. And lockout time is when the next dose can be delivered. That way they don't overdose. You want to make sure you clear the settings at the end of your shift, document how often they pushed it and how much they got, and if they are even pushing it. Make sure that only the patient pushes it, not the parents. Nobody else pushes it except for the patient, so make sure that they have education on this. On the exam, you need to know how to do the med math for how much a patient gets with a PCA pump. How you do that is really straightforward. So you're just going to take the basal dose and figure that out. So let's say they have a dose of, I don't know what a typical dose is, but you're going to calculate that based on their hourly rate. So take the hourly rate times how many hours the shift is. And then however many times they press the button, you add that up. So if your demand dose is 1 milligram, you would add up how many times they pushed it, and that's your demand dose amount. And then you add demand dose and basal rate. So that is opioids. So I would know some things about opioid-induced constipation, so those Movantik and the Relistor that we talked about, how you don't give them if you have a history of a bowel blockage or perforation. Know about PCA, Narcan, naloxone, that sort of thing. So psychological support is another thing we're going to have nursing interventions for. So this could be support groups, therapeutic communication. So you want to make sure you ask about how they cope in the past, how they feel about their body image, their diagnosis, and their attitude. And you want to give them hope, but you want to make sure that you stay honest. You never want to give them false hope. And then survivorship. So like I said in the beginning, death rate from cancer has been decreased, but you want to be aware of long-term side effects of treatment. So you also want to know the difference between palliative and hospice care, because this is a huge component of survivorship. So remember that they are both compassionate care to patients with life-limited illness, but palliative care is a component of hospice. So palliative care is more about symptom management and how we're going to manage the patient's condition while they're receiving active treatment, and is not necessarily end-of-life care. Hospice, on the other hand, is when patients have that terminal diagnosis and they have less than 6 months to live. So hospice is covered fully by Medicare and Medicaid. It can take place in the home, hospital, facility, etc. And you're basically going to help them with daily activities and meds. And some hospitals have a floor for hospice, but basically if they're going to go home, they need to have a caregiver in the home that can help them with hospice. So know that difference. And then lastly, going back to nausea, vomiting again, we've talked about, super common with chemo and radiation. So you want to know your antiemetics. So I cannot say med names if you guys have not caught on by now. So ondansetron is Zofran, and that can be given IV or PO. That's probably the most common one you're going to see. Metoclopramide or Reglan can be given IV. Prochlorperazine, Compazine, that one's also really common, can be given IV or PO. And Miranol is also the appetite stimulant. So that is all that I have for nursing interventions for chemoradiation. Very, very important that you guys know that. So like those categories, so like nausea, vomiting, the GI stuff, ulcers, just kind of how you are going to deal with your patients, because obviously chemo and radiation, they're going to have side effects. And so you want to know how to deal with that depending on where it is. And then the last thing here that I'm going to talk about is our chemo precautions. So we definitely had a question on this. Like we talked about, make sure that you're checking the IV frequently, because chemo, if you get it through an IV, you do have that risk of infiltration, and it's the chemo RN that does this. Double glove and double flush all body fluids for the next 48 hours. Chemo RN is the one that provides the education on the side effect of the drug, not the normal RN, like bedside RN. A yellow bucket is used for soiled linens or incontinence pads, and an N95 is used if they have a bone marrow transplant or if they're 6 months after a bone marrow transplant. And remember, we do that because they have no infection prevention. Surgical and isolation mask is used for other immunosuppressive conditions like organ transplant or ANC less than 500. Okay, so that is that. I am going to do your oncologic emergencies in the video with the types of cancer, mainly because I don't have time right now to do it. I need to go to class. But I will make sure to include those in the types of cancer, which I will probably film that video either tomorrow or Thursday. I don't think I'll do it today. If I'm feeling productive and have time, then I will. But I hope that that was like a good intro for you guys for cancer. So make sure to let me know if you have any questions. Watch this video. Make sure that you have a good understanding of like the grading, staging, what cancer is, caution, nursing interventions, potential treatments, that sort of thing. And you guys should be Gucci. So let me know if you have any questions, and I will talk with you guys later. See ya.